Before I begin that, let me thank all of our panelists for being here. We have a great set of panelists from all over the country, and we very much appreciate them being here. And we thank them for the work they do every day, providing health care and doing research. In our country today, I think as many people know, we spend almost twice as much as do the people of any other country per capita on health care. That's about 18% of our GDP, and yet our health care outcomes in terms of life expectancy, infant mortality, and disease prevention are not particularly good in terms of international comparisons. And one of the reasons for that is that we have a major crisis regarding primary health care access, which results in lower quality health care for our people and greater expenditures. Our fourth witness is Dr. Andrew Wilper. He is the acting chief of medicine at the VA Medical Center in Boise, Idaho. Dr. Wilper is a practicing general internist. He is the associate program director for the Boise Internal Medicine Residency Program and the assistant director of the Boise VA Center of Excellence in Primary Care Education. Dr. Wilper, thanks very much for being with us.
Thank you, Chairman Sanders, Ranking Member Enzi, and members of the committee. It's a great honor to be able to testify here today. I was asked by Senator Sanders about my insight, two insights specifically. One, about the lack of health insurance in the United States and its effect on health and healthcare outcomes, and also to share my thinking on practical solutions to the primary care physician workforce shortage that we face. So to start off, there is an enormous literature that has accrued over decades demonstrating that a lack of health insurance is associated with decreased access to health care and worse health outcomes. The Institute of Medicine summarized these findings in a 6-volume series earlier this century, and the conclusions were quite clear. Subsequent work has built on this evidence, including some of my own that Senator Sanders mentioned in his opening statement, specifically a paper we published in 2009 in the American Journal of Public Health, linking lack of insurance to nearly 45,000 deaths among adults in the United States annually. The research is consistent. Health insurance leads to significant benefits and is good for your health. So gaining health insurance does not guarantee access to medical care, which is the second part of my testimony, nor does it control costs. And perhaps the singular intervention that we could make at the national level to reduce costs and improve outcomes in our country with regard to health is to bolster our primary care workforce. There's an additional massive body of literature supporting the idea that primary care improves all sorts of health outcomes and lower costs. Nevertheless, we've not seen systematic changes to alleviate the shortage of PCPs in the U.S. in decades. So I'll talk a little bit about sort of 3 policy levers that I see that this committee could consider to increase the number of physicians entering into the primary care workforce, some of which have been referred to by Professor Mullen. First, at the medical school level, this is the period of time after which people graduate from college and are in their undergraduate medical training. We could introduce additional educational debt reduction, change federal funding streams to emphasize primary care, and increase funding for the National Health Service Corps. In addition, we could direct support to community health centers to incentivize 3rd and 4th year medical students to enter into primary care careers. Second point would be the area of graduate medical education. First, Title VII funding is specifically earmarked to go toward primary care programs, and these are continuously under threat of congressional cut and have been cut dramatically in the past 10 years. So re-emphasizing that funding would be an important step. A second piece would be direct payment by Medicare to teaching hospitals to offset the expense of training physicians. As we've heard today, that nearly $10 billion is spent by the federal government to support these hospitals, but currently we have no planning in place to actually meet the needs of our population in the United States with regard to a physician workforce. Medicare should direct funding to residency programs for education instead of directing it through hospitals. Medicare should also require assessments of community and regional physician workforce for hospitals to qualify for this funding. In its current form, graduate education is run by teaching hospitals to meet their own staffing needs or their historical staffing needs, and graduates select their field of practice based on their personal interest, to emphasize a point that Senator Murphy made moments ago. I've been personally told by a residency director that his concern is the professional desires of his trainees rather than population health needs. Perhaps the most important policy reform that we could make to reinvigorate primary care would be to address the pay disparity between primary care physicians and specialists. This could be done by raising primary care physicians' pay or by decreasing that of specialists, and I feel that it's really the disparity that is the driving force in this workforce problem that we're facing today. Indeed, the American Association of Medical Colleges has declared that education and training cannot overcome the intense market incentives that influence physician choices. A focal point for payment reform has been mentioned. The subcommittee of the American Medical Association called the Relative Value Scale Update Committee. This is a secretive group of doctors that wields tremendous influence over Medicare reimbursement rates. And the CMS adopts nearly all of their recommendations. At a minimum, the public deserves transparency in decision-making from the RUC. Better yet, we should establish a process for rate setting that is not encumbered by conflicts of interest and does not favor narrow specialties. A rational observer might conclude that the federal government and AMA are colluding to bring an end to the primary care physician workforce in the United States. In summary, it is eminently clear that health insurance affords better health outcomes, including a decreased risk for death. Despite this, our current reform efforts through the Affordable Care Act will leave 30 million uninsured. And in closing, I've worked for over a decade in medical education as a student, resident, fellow, and now faculty member, hospital and residency program leader. And it's my conviction that publicly sponsored training should be planned to meet the healthcare needs of our population rather than the staffing needs of hospitals or the lifestyle preferences of young doctors. Thank you.
Thank you very much, Dr. Wilper. My understanding is that Senator Franken has to leave, and you wanted to ask a brief question to Dr. Wilper. Is that correct?
Thank you, Mr. Chairman. I mean, you're. I guess yes. That would be a yes. You know, you're talking about the compensation. You probably heard my comment earlier about the return on investment in terms of loan forgiveness for primary care physicians. What would that look like? In other words, I know we do some loan forgiveness in ACA. We do it for people serving in underserved communities. What would that look like, and how could you compute that in terms of what the value that you would get back over the course of a physician's career if you said, okay, if you go into, if you're a GP, boom, $100,000 off of your loan?
Dr. Wilson.
Have studies been done to do that? Has that been looked at?
Senator Franken, thank you for the question. To my knowledge, there is no systematic review of that specific question. I know in my home state of Idaho, which is a neighbor to Wyoming and also exceptionally rural, we do have programs in place to help offset educational debt related to medical education, and those have been somewhat successful. I would defer to my panelist to my left, Dr. Reinhardt, who may be able to.
Dr. Reinhardt, since you're a medical economist, may I ask you that?
Microphone, please.
If you have more primary care physicians, that'll improve access, and the Institute of Medicine studies that were cited shows that that'll produce better health and life years, and we economists can convert that into quality-adjusted life years. And usually the assumption is a value is imputed to that. Normally, I know David Cutler and others use $100,000 just to put a value on it, and then say, by having more physicians in that field and providing better access, how many QALYs have you produced, life years saved or better quality of life, and you would get the return. I suspect it would be fairly high.
Yeah, I would love if that could be done.
Be a nice senior thesis. I'll ask a student something.
Okay. Since I just got 2 minutes left, and then I'll just go.
Well, that's all you have left anyhow.
That's what I meant.
You're not doing us a great favor here.
I was making the same point. I'd like those 3 seconds back and I'd like to Senator Murphy's question about or comment about the status of. I think your status is partly determined by your salary. So I do think that the relative value board that you were talking about, I can't remember the name right off. In other countries, what is the compensation like in terms of general practitioner to specialist? Is it different? Is it lower? Is the ratio higher to GP to specialist in other countries versus here?
Specialists do earn more. I know, for instance, in Germany, but not as much as they do here. More. So GPs generally do have lower pay and occasionally protest about that. Happens over there. But I don't think the ratio is quite as large. There's also a huge.
And they have lower health care costs and as good outcomes, if not better, right?
About half, yeah.
The health care costs. Okay, I just want to do this for the. And Senator Murphy again brought this up. Accountable care organizations, which we have a lot of in our state, and health care homes, medical homes. Would they elevate the role of general practitioner in that model, in the sense that they would be sort of organizing this team that does the care? Does anybody have an opinion on that?
So specifically with regard to ACOs, unless fee-for-service payment mechanisms are changed, and there's a proposal to do that in these new medical home models to move to a capitated system, there is some chance that would move the needle in terms of primary care physician reimbursement. I would caution, however, I know this research fairly well. There's very limited evidence that patient-centered medical homes are actually going to reduce costs. And so I think that intervention, while worthy, and we're working on it at the state level and within the VA, is still, in my view, experimental.
Okay.
Well, okay, I'm sorry. Thank you, Mr. Chairman, for that. And I just want to, just one last thing, Ms. Declever, I really thought it was really off base for the ranking member to use your willingness to come here to testify to moan about his weekly commute.
Okay, let me switch gear for a moment and touch on another very important issue in terms of how we determine reimbursement rates for physicians, and that is the RUC, which I think probably is not a household word throughout America, and yet is an organization which plays an enormously important role in determining how much specialists will make, how much primary care physicians will make. And apparently we have an organization which is kind of loaded, top-heavy, with people in the specialties and weak in terms of representing primary care physicians. Is this an important issue? Dr. Mulligan, you want to take a shot at
that? A key issue, when we talk globally about the idea of pay inequity, how do we get a handle on it? Since Medicare is the largest single payer, and historically many private payers key off Medicare in a variety of ways, managing the Medicare conundrum around the pay gap would be central to reforming the whole system. And the RUC is at the center of it. It's well-wired in the sense of it's been this way in a long time, and there are a variety of approaches to it. But I think just sunshine, daylight, focusing on this, you have lurking under it the question of, do you raise the floor or bring the ceiling down? Both will raise all kinds of issues for people involved, and philosophically and politically as well. I believe it's both. I mean, the point is we're not going to pay all our primary care physicians $500,000 a year, but I must say as a physician and a citizen, when I hear about a physician making $500 or $1 million a year, yes, there are people in business that from their college class, et cetera, I think it's a moral argument we need to engage as a country.
Dr. Wilper, you had some strong words on that, and we'll get to Dr. Reinhardt.
Thank you. So I do have some additional thoughts on this, and specifically the process by which the RUC evaluates billing codes between the different subspecialties and primary care. This process could be improved by reevaluating the evaluation and management, what are called CPT codes. An example of this is as follows. An ophthalmologist will bill the same code, a 99214, for a 10-minute exam with very little follow-up needed. A PCP, a primary care physician who performs or who bills the same code, generally spends 25 to 30 minutes with the patient face-to-face, has 25 to 30 minutes post-care documentation and follow-up, and an estimated 20 to 30 minutes between visits for the same patient. And now the reimbursement for those two services are identical. So what we need is a new E&M codes in primary care. We need to update our knowledge base regarding this issue, as current time estimates for these codes are actually outdated and are dated to the 1980s, 25 years old, and they're based on very small sample sizes. So the proposal would be to develop an independent process for reviewing these codes that is transparent, peer-reviewed, and based on real-world data.
Dr. Reinhardt, you want to make a briefly, please?
Yes, the RUC determines relative values, not absolute levels, but it's a zero-sum game if it's budget neutral. One could put more primary care members on that board, and I think that would be a good idea. But MedPAC had also proposed that there be an outside committee, an independent committee of stakeholders who kind of audit and review the RUC recommendations. I don't know if that ever went anywhere, but I would encourage you to look at it and maybe go that way.
Okay, thank you very much. Senator Enzi? Thank you, Senator Enzi. Senator Warren.
Thank you. So, like Senator Enzi, I'd like to follow up with some questions about community health centers as a vehicle for delivering primary health care. And it's their impact on access, on costs, and on disparity. And I was very interested. I read through all of the testimony and very impressed by the work you've done, Ms. Koenig. I mean, it's terrific work. I was very glad to hear Ms. Declever about the work that's done out in Wyoming, that you've got community health centers there. But what I'd really like to know is what else do we know about them in any of those dimensions? Either, as I said, it's about cost, it's about access, it's about reducing disparities. Can anyone speak to that? Dr. Wilper, your head snapped up, so I'm guessing it's you.
Sorry for that.
No, I like it.
So I actually, in addition to my work at the VA, I also work at a community health center in Boise, Idaho, called Terry Riley Health Systems. And in my experience, the CHCs provide just a critical safety net for the uninsured of our valley. I live in the Treasure Valley. The uninsurance rate for this population is nearly 50%, which is actually second highest in the nation. My experience as a clinician working in that clinic is that despite the access that it provides, oftentimes there is what we end up providing is care that, at least in my other job at the VA, we wouldn't find acceptable because we don't have other resources to offer to these patients seen in our community health center because they don't have insurance. So even though they have a foot in the door to the clinic at the community health center, oftentimes patients are unable to access additional services that would be standard of care in any other system in the U.S.
Very helpful. Yes, ma'am.
what their experience is.
Dr. Wilper, you expressed skepticism based on the literature as to the cost savings that medical home models may provide. ACOs are a little bit different. What do we know about the ability for ACOs with perhaps primary care specialists, primary care doctors elevated to get cost savings that maybe we haven't seen in some of the early rollouts of medical home models?
To my knowledge, we know actually very little about how ACOs will reduce costs or what their effects on costs will be. What we could look to is the model of care where I practice, which is in the VA, which is sort of the ultimate integrated care model, right? We have people for life after they return from service and do a very good job taking care of them. And it is my understanding, though I don't know this literature in its entirety, that we provide care that is of similar or better quality to most private institutions in the United States at costs that are much lower.
One final question to you, Dr. Wilber. You had a provocative statement at the end of your testimony about the interest that the AMA may be serving here. Can you elaborate a little bit on that?
Happy to, thank you. So my personal position on this is that this subcommittee of the AMA wields inordinate power over physician rate setting, and I know we're trying to get away from remuneration, but the federal government is sending a very clear price signal to students about what they want them, what the federal government would like them to practice in. And I think to minimize that is a little bit dangerous. My personal view is that physician groups treat public payers as though they were their own entitlement programs rather than a source of coverage for the U.S. population.
We're out of time. Thank you.
Thank you, Senator Casey. Let me conclude by thanking all of the senators who participated in this hearing. I think the large turnout tells you how seriously many of us feel about this issue. Most importantly, I want to thank all of our panelists for their wonderful testimony and to tell you that we are going to listen very seriously to what you had to tell us. And I especially want to thank those who came from such far distances, Ms. Decklever and Dr. Wilper, but thank you all very much for your help. Okay, this hearing is adjourned. Thank you.